Well, it's 9:01, and I always like to start things on time. So let's get started because I know you're all busy. So good morning and welcome. My name is Lorna Matern, and I'm the Executive Director of the United Counseling Service. We're pleased that you're here to join us this morning, wherever you may be joining us from. No matter how we are able to get together, it's always great. It's always really important to us. And unlike years past, we actually did not invite community partners in hopes of creating a little bit of an opportunity for increased dialogue. And rather than using our time to introduce everybody, I'd like to welcome our board of directors, our senior leadership team, and there's a few staff that are also here as well. And if you make questions or comments, please introduce yourself at that time. That would be great. I'd like to welcome our honored guests, Senators Dick Sears and Brian Campion. Good morning to you.
Good morning.
Seth Bongards, Tim Corcoran, David Durfee. I'm not sure if Mary's on yet or not. I'm not sure if I saw her, but Mary Morrissey is expected to join us.
She's on.
Oh, good. Good morning, Mary. Michael Nigro and Dayton Whitman. I'd also am pleased to introduce and welcome Tafine Dean, representing Congressman Peter Welch's office, and Beth Stern, representing Senator Sanders' office. We really appreciate the both of you joining us today too. And if you don't mind, I'm going to put you on the spot right away because I'm not quite sure how much time you have, and we'd really love to be able to hear from you about sharing Senator Sanders and Congressman Welch's priorities related to substance use, mental health, and developmental disabilities. So if you don't mind, would you mind starting us off? Really putting you on the spot right away.
Sure, thank you. Thanks for having me and for having us. So I'm Beth Stern. I'm an outreach representative for Senator Sanders, and I cover the areas of healthcare, seniors, disability, economic justice, and temporarily education and nutrition. So I'm really honored to be here representing Senator Sanders. He is on his way back to Washington today. He wanted me to send his thanks to the staff and the partners of the United Counseling Service. The work you do as the designated agency for community mental health and developmental services is really, really vital, especially now in these challenging times. Your work is more important than ever. We know that the pandemic has exacerbated an already really difficult situation, not only for your clients, but for the agencies which are struggling to maintain a qualified workforce. And he knows that all the staff there, the psychiatrists and the psychologists, social workers, substance abuse counselors, the case managers, the residential staff, administrative staff, and others provide services for individuals, children, youth, and families, including Head Start and mentoring, developmental services, emergency services, psychiatric services, mental health, and substance use disorder. So all of this is really, really hard work and helps so many people maintain and improve their mental health and ability to cope. In DC, Congress is still trying to pass the fiscal year 2022 budget. They hope to do so by the middle of March. I've been saying that for the past 3 months, that they hope to do so by X date, and X date comes and it goes and they push it out even farther. So it's really, really frustrating to Senator Sanders that we don't have a fiscal year 2022 budget. And that means that it's really hard to start working on fiscal year 2023. So in his work in DC, Bernie is still working to pass Build Back Better, or some version of that, which was passed out of the House of Representatives. Thank you, Congressman Welch, but stalled in the Senate, mainly due to 2 senators who objected to it. Build Back Better includes significant and needed improvements, investments in mental health and substance use disorder care. Ideally, Bernie would like our healthcare system to fully cover mental health and substance use treatment. He also supports increased funding for dental, vision, hearing, home and community-based long-term care, reproductive and maternity care, and more. Last week, he introduced a bill to reduce prescription drug prices, which it was introduced, but that's as far as it's gotten right now. And finally, he wants you to know that even though the Senate currently seems unable to pass much meaningful legislation, he has not given up fighting for these issues. So he is very aware of the challenges you're facing, again, both for your clients and for your staffing. He's doing a lot of work right now on medical workforce, particularly nursing workforce, but it includes workforce in general, and is really hoping that he can make some meaningful change in these issues that are affecting your lives and the lives of your clients. So I can stay on a little longer. I also will put my email information in the chat so that you'll have that in case someone wants to reach out to me afterwards. And certainly I'll be here for questions if you have them.
Great. Thank you, Beth. I appreciate it. Any questions for Beth right now, or? Okay. Tafine.
Hi, everyone. My name is Tafine Dean. Thank you for having us today. I, like Beth, work as an outreach representative to Congressman Welch here in Vermont, and I cover healthcare, human services, housing, disabilities, seniors, racial and social justice, and refugees. And so a couple of weeks ago, Congressman Welch had a press event around home and community-based services in Build Back Better. And I was just going to go through a little bit of the provisions in Build Back Better that would help home and community-based services, and then talk a little bit more about Congressman Welch's priorities in terms of the mental health space and substance use disorder. I know that Lorna, you've been part of conversations with Peter, and I believe there was a lovely summer meeting outside that was supposed to be inside, but he was like, it's too nice, let's have it outside. So happy to go through those and happy to answer any questions. So in terms of Build Back Better.
Either.
And was it plugged into the
Yep.
hardwire?
Yeah. I don't know.
I'm sorry, Betsy.
I'm sorry. Sorry, I didn't know I will get off. Sorry.
So in Build Back Better, there's a historic investment of $150 billion in home and community-based services. How that sugars out is to an FMAP increase, and then also an increase in investments into the actual provision of home and community-based services through the Community and Behavioral Health Program. This is a recognition that families and organizations like yours spend so much money on providing these services, and there has been a historic underinvestment into these services. And in order for us to really move the needle on our mental health crisis that has been exacerbated by the pandemic and substance use, we have to invest a significant amount of money into providing these services at a community level, and understanding that you all who provide these services know best how to spend this money. So the FMAP increase really is the direct provision of money for you all to spend in investment of your workforce, investment in your services, and that's why sort of the investment is less in sort of specific programming, but an FMAP increase overall. One of the biggest issues that we've been hearing about is the workforce crisis. And I know that Lorna, you have talked to me and Congressman Welch about retaining and paying your staff equitably. And that's something that Congressman Welch is always looking at. The Mental Health Improvement Access Act that he's sponsored continuously for the last 3 Congresses, I believe, is a way of increasing that workforce by allowing providers other than just licensed psychiatrists to be able to provide mental health services. I can share that information of that bill. This would allow marriage therapists, licensed social workers, and the sort of spectrum of healthcare providers to be reimbursed by Medicare. We're hoping that this would allow to sort of remove some of the bottlenecks that we're seeing for this workforce. Another initiative that Congressman Welch is working on in terms of workforce is looking at travel nurse agency staffing and sort of price gouging with these agencies. We know that the hiring of travel nurses is so important to our providing of care in the state, because without them, we could not do this work. But there's also a recognition that private equity firms who sort of own these staffing nurse agencies are charging so much money to you all for these folks, and if there is this price gouging, then Congressman Welch wants to understand what that means and how that's impacting you all. And another priority for substance use disorder for Congressman Welch is the investment in the substance use block grant. And as you know, in the American Rescue Plan and in the December Consolidated Appropriations Act, together there's been about 12 million coming into Vermont for the investment in substance use programming, and $6 million coming into Vermont for mental health programming. So Congressman Welch will continue to advocate for these, for the resources and the funding. It would be great to hear from you all as well as to what more you need, or how, if there's any regulatory hurdles to some of accessing some of these funds that we could help with. And I'll just end by saying peace on prescription drug reform, like Senator Sanders, that is a high priority for Congressman Welch. And one of the key wins for him in passing Bill Back Better was getting not all of what he wanted in prescription drug reform, which was HR 3, which is Medicare negotiation, but what we were able to get was a cap on what Medicare patients could pay on their out-of-pocket costs for prescription drugs, and a cap on insulin, which is a big win for us, but we have to take what we can get in the negotiation process. I'm going to stop there and happy to answer any questions, and I can be on till 10. Thank you.
Great, thanks, Tafine. Any questions for Tafine? I do want to just identify the Medicare piece. That's certainly an obstacle, as you know, and as Peter knows, for us to be able to provide service to elders. And we're turning people away all the time because we just don't have the very narrow license available to take on all the people who need it, services from us who have Medicare. But that would be just a huge shift in us being able to provide services to elders in Bennington and in Vermont. So absolutely in support of that. And you also mentioned workforce, and I think it comes as no surprise to anybody that I am going to talk about workforce to start off with. And I'm sure that folks in the legislature have heard quite a bit, and you get to hear a little bit more this morning. And so, as you know, UCS is the designated mental health, substance use, and developmental disability agency for Bennington County. And we provide comprehensive 24/7 care in a variety of settings, including community, school, emergency departments, and group homes. And in addition, we have a robust Head Start and Early Head Start program, as Beth had mentioned earlier. We serve 3,000 Bennington County residents and employ approximately about 275 staff. And throughout the year and the entire pandemic, it remains open and fully accessible to our community. Last year, I mentioned, I actually specifically said that a mental health and substance use tsunami is fast approaching that will have ripple effects, the scale of which we have never seen and will last for years to come. Unfortunately, that is truly the case. Demand for services is at an all-time high. Substance use disorders and mental health conditions such as anxiety, depression, overdose deaths, and suicidality have increased for children and adults, especially for people with disabilities, students, families, and isolated older Vermonters. The demand for services has never been higher and will not subside anytime soon due to the long-lasting effects of the collective trauma that we are all still experiencing. UCS continues to experience a high volume of calls. Last year, we saw a 135% increase in calls as compared to 2020, and the rate of increase has not changed. Despite that, we have been able to offer 88% of the individuals who call for an intake appointment within 5 days of their first contact. That is unfortunately a drop from last year by about 5%. We can provide 74% of those individuals who complete an intake to see a clinician within 14 days. And in a little bit, you'll hear from Lori Vatican, who's going to talk about how we've responded to that as we continue to innovate. The data for substance use disorder is far more alarming, as you all know. Vermont has seen a 38% increase in overdose deaths over 2020. The national average of deaths due to overdose is 28.3 per 100,000. Vermont is higher at 26.8 per 100,000, and Bennington is higher still at 36.7 per 100,000. The U.S. Surgeon General Vivek Murthy testified to the State Senate Finance Committee last week of the pandemic's devastating impact on youth mental health. He stated, and I quote, "The obstacles this generation of young people face are unprecedented and uniquely hard to navigate, and the impact it's having on their mental health is devastating. We are not doing enough to provide adequate care and treatment options in every community, and the pandemic has only made the disparity worse," unquote. The designated agency's dream and UCS's dream of health parity has been deferred yet again. For far too long, UCS and the Vermont's designated agency have been left behind while state government has supported its own workforce and infrastructure with annual increases for wages, health benefits, and other operating costs. This could be remedied by increasing the Medicaid rates for United Counseling Service and the entire DA system as a whole, as it is currently insufficient and not in parity with other health providers. And that disparity has had a debilitating effect on our local system. I think Tafine had talked about the FMAP increase, which is a great first step to having equity within our Medicaid reimbursement. I would like to introduce Christelle Mannon, who's a school-based clinician and who's here to share a little bit about working within UCS as a designated agency and in schools and working through the pandemic. Good morning, Christelle.
Good morning, Lorna. Hi, everyone. I didn't expect to go first, but hi, I'm Christelle. I've been working at UCS for almost 4 years now, and I've worked my way through different roles. So I've been a case manager, I've been a coordinator, and now I'm a clinician. And for me personally, it's been really challenging continuing to work at a designated agency because of some of the financial difficulties that we have to constantly make. Not to mention, it's disheartening to know that like people that are mentors to you who are also clinicians tend to cycle out because they have to make those decisions for their own personal growth or for their families, so that way they can provide for their families and whatnot. And that's really hard because we rely on each other. We ask each other questions all the time. We just rely on one another based on their experiences to ask questions, and it sucks. I'm going to say it sucks when people leave, because then you're kind of stuck with the burden of high caseloads, high levels of stress and burnout, and then there's a lack of clarity around specific roles within designated agencies. Not to mention the copious amount of paperwork, which tends to take away from the quality work that we're providing to our clients because of how much paperwork we have to complete. And that also factors into, why people leave. Let me see, I wrote it down, sorry. For Vermont, I chose to live here. I'm not from Vermont. I chose to stay in this county specifically because I wanted to. I love living in Vermont, but it can be really challenging when, coming from a city, you're financially compensated appropriately, and then coming here, it looks different because, there are either less jobs, or, it's a smaller state or less people. And so that's definitely different. and who was it? We had a town hall meeting recently, and one of the things that was mentioned was how the designated agencies have to compete with other like areas such as like Albany. But I wanted it to point out that even Brattleboro is close to us. In Brattleboro, the demands are still the same, but the financial compensation piece is higher. And so, that creates a difficult decision where you either will travel all the way to Brattleboro if you live in Bennington, and if anybody knows, that's a hard drive. Or, it's hard. And in the schools, we're getting slammed too. I can't split myself in two, and caseloads keep increasing, whether it's, the need of kids for anxiety or behavioral concerns, not to mention the population that we work with here in Bennington. It's just, it continues to be an endless cycle, and it continues to be, it continues to contribute to systematic flaws. And so I hope that we can fix this dilemma, because it's in the schools and all the kids know it. And, all the kids know that there's a lot going on. And then within the community, we can see the effects of the pandemic. We see it, whether it's overdosing, increase in substance abuse, retention at jobs, and just it's affecting us deeply. And that's all. So I just wanted to say that.
Thanks, Chriselle. Appreciate it. Appreciate your honesty. I appreciate the work that you're doing in schools, because I know kids are really very much suffering. So thank you for the work that you're doing and hanging in there with us. So we are deep into a public health emergency due to the combination of the profound impact of COVID on Vermonters and the workforce issues. And UCS, as the community safety net, is simply unable to respond to it. The current labor market has us at a breaking point. Staff are able to earn equivalent or higher wages at grocery stores and restaurants. Those who do leave us but continue to work within the social service sector, such as schools or DCF or even the FQHC, are making upwards of $10,000 more a year. And this mass exodus is drastically impacting service. An example of how the severe workforce issues are having a detrimental effect on those we serve comes from Kendi Skidmore. Kendi is a parent whose children have received services from UCS. I think Heidi has a video that she will share.
Yep, here we go. Wish me luck. Let's see.
This is always the time where we cross our fingers.
Can you all see that?
Yes.
Okay, here we go.
Hi, I'm Kendi Skidmore, and I'm a member of the Children's Advisory Board. More importantly, I'm a parent of children receiving services through Children's Services at United Counseling Service. I've been a foster parent for many years and have adopted children through that system. Most of those children have received services. Most of the foster children that I've served have received services through United Counseling. And I have never experienced the turnover and the lack of support that we've experienced the past year and a half, maybe even a little bit longer. The turnover here is remarkable. My children don't even get to know their worker before they're leaving to take another job. So I feel like most of their time is spent getting to know them, or the workers getting to know my children, just in time for them to transition them into, well, I'm leaving to take another job, so you'll get a new person. It's very frustrating, and it's not beneficial to my children at all, or to me. No, the good work doesn't happen when they're spending all their time transitioning. They're spending all of their time meeting new people. My daughter, for example, has had several case managers in the past couple of years. One of them most recently came on, met with her a little bit each week and said, well, I'm just trying to get to know her. And then before I knew it, she was telling me that she was leaving for another position. And I said, well, does my daughter know that? And she said, well, I've kind of been transitioning her. We've been talking about it. Yet just a week or two before, she had told me she's still building a relationship with her. So at the same time she's building a relationship, she's preparing her for her to leave. And a new worker came on right away this time, which was impressive, except that the whole first meeting was spent talking about what do we hope to receive, what do we hope to get out of these services, what is my daughter, what are her challenges, what are her interests, those kind of things. It's the same thing that she tells every worker that she meets. And so it's just repeating it all over again. And for kids who are experiencing trauma or who don't like to talk about their issues, it's just repeat every few months, every 3 months, every 5 months. It's very discouraging. And I think that we need to do something so that these folks are staying longer, so that they're committed longer to these positions, to these kids, because there's a huge number of kids in this community that are needing that support, and families that are needing that support from United Counseling Service, and they're not getting it. They're on waiting lists, or they're waiting for a worker, or their worker has left and we're waiting to hire a new one. We have to do something to retain these staff. So whatever you can do to help would be greatly appreciated, because our kids need these services, and we need to help them. Thank you.
UCS has increased recruitment and retention, from sign-on bonuses to retention bonuses to hosting job fairs. And we've even actually have a billboard advertisement. We went very old school. And yet, in spite of the efforts, we remain a system of care in crisis. And to Kendi's points, our turnover rate is 34%. The turnover rate for programs that provide services to those with a developmental disability is even higher. We have at least 43 vacancies. Some clinical vacancies have been open for more than a year. Staff are working upwards of 100 hours per week to keep group homes open and crisis services available. Staff are leaving for better pay with less risk, resulting in 61 children on the wait list, 80 adults waiting for services, and an increase in the number of children and adults accessing the emergency department for their mental health care. And of course, I'm sure you've all heard about the very long waits in emergency departments for days and sometimes weeks. We have been handed an unprecedented opportunity to invest in mental health and substance use prevention and treatment, as well as developmental services and supports. Thank you for your support to set aside $60 million in this year's budget adjustment bill to pay for retention bonuses to frontline workers across the human service sector. We know that staff will undoubtedly appreciate the recognition. However, we need to have predictable rate increases that align with other healthcare sectors to make any lasting impact. So here's the big ask for your support. We need an increase in Medicaid rates of 10% in FY23, and a commitment to increase over the next 3 years to achieve parity with healthcare. We are 12.5% behind that of healthcare. Once funding parity is achieved, require the administration to set predictable scheduled rate increases that align with the rest of the healthcare system. And then it would be wonderful to be able to have folks stay for retention, and also as a way to bring young people into this career is to develop and expand educational opportunities such as tuition assistance, scholarships, and loan repayment for workforce development. And ultimately, we simply do not have a robust healthcare system for all if we do not have a fully funded behavioral health and substance use system. So I just wanted to pause there for a moment before we move on to Lori Vatican for any questions, comments, anything at all. Yes, Mike.
Hi, thank you. I'm going to ask this question partly because the Commerce Committee has been working with the Healthcare Committee on a number of workforce issues, and I just want to be clear if there are certain levels of credentials that are the biggest area. I mean, I assume to some degree there's pressure across the board, but are there certain positions that are the biggest difficulty for you to fill?
Yeah, so right now, I would say, well, there's a couple of very difficult positions to fill. One is emergency services. We have, I think, and Rachel, our assistant medical director who oversees emergency is here too, that she can correct me if I'm wrong. There are four, I think currently 4 full-time crisis workers covering 24/7 and almost three positions open. 2 positions open?
Yep, no.
Oh,
We have two full-time emergency clinicians to cover 24/7. So, which means that myself, a nurse practitioner who, may be better utilized in treating patients here in the office and providing psychiatric treatment, I am now covering emergency services so that our community is not without services. So when I came onto this position, sorry, Lorna, I'm just like taking over.
You go right ahead, Rachel. It's important.
When I came into this position in August, from August to now, I've had 4 clinicians quit and move on to different agencies who can pay them as much as $20,000 a year more than we can. So, and this work is high stress, it's long hours. We're going all over the community, sometimes in potentially unsafe situations. So, to have an option to go work at a school for higher pay, shorter hours, summers off, why I don't blame them. Why wouldn't you? Unfortunately, the designated agency is expected to be the experts, right? But we are not able to retain employees long enough for their expertise to really benefit the community. So as soon as we get them trained, they're off to somewhere else. It's really physically impossible to expect 2 full-time employees to cover however many hours are in a 7-day week. I don't know. It's just, it's nuts. And, I don't have anything to offer, these people, and we have 0 applicants, 0. So.
And I'm sorry, just again, just so to be clear, when you're referring to these crisis workers, is that MSW? What level of certification or education are we talking about?
Master's level clinicians.
Yep. Master's level clinicians, ideally licensed clinical social workers.
And that's the same. I'm sorry, that's the same, Mike, for outpatient services. Our master's level clinicians, licensed mental health clinicians are the positions that are open the longest and allow us to be able to bill for all of our services and all of the insurances. The other thing that we're having really difficulty in hiring are folks to cover our group homes. So developmental services, we have 3 group homes. and coverage for those group homes. They're sharing their, staff from other programs are covering. We're cross covering, which is why people are working 100 hours or more a week to cover. And they're the least paid jobs. So right now we've increased our minimum to $15 an hour, but these are jobs that they're providing medical care, end of life care, activities of daily living, so bathing, washing, feeding, and they're really important positions, and they get paid the least, working with the most vulnerable, and we're really having a hard time in recruiting those positions as well. David?
Thank you, Lorna. Thank you, everybody, for what we've heard this morning. Lorna, you mentioned a couple of months ago the retention bonuses that are in the Budget Adjustment Act that would go out before the end of the fiscal year. Can you say anything about how important you think those would be to right now to addressing issues? There's a little bit of disagreement on whether they should be in the budget or not.
It's a great question. I think they absolutely help in this point in time. So, and maybe Chriselle or others who've received them could say, I think that in this point in time, absolutely, it's helpful. I think people get a little bit jazzed about it. I think they get a burst of energy to kind of stay because they're feeling recognized and hopeful. But the reality is that doesn't last very long because it's not in their weekly paycheck. It's not coming on a regular basis. So it's really more of a long-term shift versus a one-time. And as I said, that one time is incredibly appreciated, and people will pay for their oil. People will get their car repaired. People will do things that they've been putting off for a really long time because they can't afford it, frankly. So it really actually really alleviates some pressure, financial pressure.
So is it more of a boost, psychological boost than an actual tool for retaining staff or getting staff to stay on longer than they might otherwise have?
I think it helps staff stay on a little bit longer. Leslie, Leslie's our HR director. Is there anything that you want to add?
I would agree with how Lorna's describing it. I do think it's incredibly helpful because it does address financial need, but it is a short-term show of both acknowledgement and appreciation. It's not the boost in salary that somebody sees that we're competing with, which is the thousands of dollars more annualized every year. So yes, it's incredibly helpful. It's incredibly necessary, but I think it is a short-term solution.
Brian, good morning.
Good morning. Thanks everybody for being here. One question I had, again, related to all of this, and I think Mike touched on it a little bit, is there something we can do specifically as it relates to higher education? And I know, I chair Senate Education, and we have been working really hard at what is going to become a massive teaching shortage crisis. I mean, we're experiencing it now because we have so many teachers that are leaving the profession, some retiring early, some teachers have given it their all. I can't say that enough. And I know all of you have as well. And so we are looking at ways to partner with our state colleges and our private colleges to make sure that we are not hit as hard or to soften that blow as much as we possibly can. And so I'm just wondering, have there been conversations? I know the state colleges are focused on this a little bit, I know, but I'm wondering if you're in regular contact with the state colleges. I also know from my work at Bennington that Bennington is open to these kinds of conversations around workforce. I'm just wondering if any of those kinds of conversations are happening at this level. Is there anything that I can do or any of us can do to help facilitate those things? And I also realize that, this is a now issue, so getting somebody to finish, or recruit somebody for a 6 or 4-year program or even a 2-year program might not be the best way to go. I mean, it helps in the future, but I also recognize that this is a problem right now.
I think it's a great question. So I think it does help in recruiting and keeping staff. So there's a couple of staff that I can think of right now, and Rebecca is on the screen somewhere, who are currently receiving, going after their master's degree. Part of the reason why they're able to do that is we can provide a little bit of flexibility for them to do that, but they're also receiving, like through Head Start, they receive quite a bit of TNTA money. So they're able to use some of that for helping with tuition. We have a couple of staff who we think would be great to be able to go through a master's degree program, but they don't have a way of paying it, and neither do we. So I know that at one point the state colleges, I think UVM, if you get a master's degree on paid for, as long as you commit to staying within the state system for, I think, 5 years or something. I don't know the details, but to be able to offer something like that would be a tremendous boon for being able to keep people in Vermont, keep people working, growing within our system, guaranteeing some expertise that Chriselle was referring to, keeping them post-license, that we train them and get them licensed and then they move on. But being able to get licensed and have a commitment to stay for loan forgiveness for 3 or 5 years would be an amazing opportunity for people in the community for treatment. We've had some conversation, I think, with CCV around developing some certification programs for like direct support professionals that work directly with clients. We know through some studies that we're going to be short for direct support professionals, like 1 million short in the next 10 years. And those are folks that are going to be working with people in nursing homes and group homes and so forth. And to be able to create an opportunity to bring new young people into that field by paying for education, paying for certification, and then of course paying them a livable wage is helpful as well. We have not, to my knowledge, talked to Bennington College, other than I had a conversation with them about their student population and their mental health and how we can support them there, but not necessarily from a higher education point of view. But I will reach out to them now that you mentioned it.
Yeah, and one of the things you mentioned that we've heard in our committee as it relates to teachers is that student loan relief. I mean, if there is an opportunity to give people that kind of relief, it's tricky, and particularly I think for UCS because we're so close to Albany, so close to Massachusetts. People can say, hey, New York and Massachusetts are going to pay us more. Are there things that we can do? And I wonder even if I maybe look to Dane, because I know he's on health and welfare on that side, to get some money in the budget on the House side before it comes to us for that kind of relief could be helpful. And then I'm going to have to leave about 10:15. And I just want to say that, without a doubt, social and emotional health of kids and trauma is front and foremost in my committee. We're going to be we made a lot of recommendations, as you know, last year to appropriations for after school support and summer programs. We're going to continue to do that. We're working with the Agency of Education on a recovery plan. We know, and we have heard from teachers around the state, in particular in Bennington, that unless we get this social emotional health issue under control, there's no reason to talk about, or it's impossible to talk about learning math, learning how to read, all those kinds of things. I mean, that is really what has to happen. And so that's certainly on our list. I'll just say one story around the social emotional health. A colleague of mine has referred a couple of times to her grandson who started kindergarten in northern Vermont when the pandemic hit and is now in 2nd grade. And so this little guy has been in and out of school with remote, not in school, not socializing with peers. This is not going to be a 1-year, fix. This is a decade, if not more, working with young people to make certain that they recover from this.
Yeah, absolutely. And, I appreciate that there's some discussion with schools around the social emotional piece. And I guess what I would say to you, Brian, is figuring out a way that, I think the schools have gotten some infusion of funds around mental health. And I guess what I would recommend is for schools to buy, not build. So rather than schools creating their own mental health service system within the school system, is continuing to use the collaboration that they have with the mental health center, UCS and beyond, since we are the experts in mental health, to be able to work with us, to be able to have
makes sense.
clinicians in the school versus building their own.
Right.
And if we can pay them better, we'll keep them and we'll hire, be able to hire. So thank you for the work that you're doing, Brian.
No, thanks. Many thanks to all of you. And people know how to reach me.
Yeah.
Thanks.
Dick? You're muted. Oh, there you go.
Finally unmuted. I think that's one of the biggest things in Zoom is being muted and unmuted.
Absolutely.
I can't say enough about, the conversation you just had with Brian about all the things we can do, but the immediate problem that I see is both recruitment and retention. And the Senate Appropriations Committee, which I'm a member of, we added recruitment to the retention bonuses that the House had in the budget adjustment. And that is going to be a bone of contention between the two as we try to settle that. And I don't know if we're going to end up with a conference committee or if the House will just say, yeah, Senate, you got it right, that retention is important, but recruitment is also important, because if we can't get people, we have shortages everywhere. You look at throughout social services, corrections, and our local stores and all that. So I'm convinced that we need to do better. Now, the 10%, I just want to give a little bit of reality here. The governor put 3% in his budget.
Mm-hmm.
It should have, we all know that we'll increase that. But can we get to 10% in this current budget environment? We're going to make an attempt, but it's not just UCS asking for 10%. It's not just the mental health and designated agencies. It's our home health agencies. It's our nursing homes. It's throughout the social service structure. And unfortunately, the governor sort of put about a 10% increase in for state employees, including their benefits. Wow. So, I was looking at, I think it was Department of Mental Health, where they put in 6 new positions at $800,000. And I scratched my head wondering, why would you put in 6 new positions when you can't even fund what you've got in the local communities? And thus far, they haven't been able to answer that question. But I think you need to continue to put the pressure on not only your legislators. I think most of us agree that 3% is like, in this day and age, when I go to the grocery store and the price of a bagel is tripled, well, maybe not tripled, but you get my point. The cost of living is so high that 3% is almost losing money. Mm-hmm. So I think you need to put pressure on the administration. And I think you need to continue to ramp that up with the Commissioner of Mental Health, in your case, the Commissioner of Dale, as well as others in the administration. They seem to have left it to us to come up with the money. And that means we have to cut someplace else. And, I'm willing to do that to get there, but it's the what else.
Yep.
I have one other comment or question, and that is, have we lost treatment on demand at this point? Is that a no longer available to people who are in crisis? Now, I guess that's an important question for all of us to understand the magnitude of this crisis.
Yeah, we have not we have not lost treatment on demand. Certainly, crisis is available 24/7. You know, Rachel talked about having 2 full-time staff, but there's also staff that are covering, so we're making sure that we have it. Now, that doesn't mean you're not going to have to wait, and that there's some triage that has to happen. Certainly, you know, Rachel was in a situation where there was a very dangerous situation occurring that I think she spent 3 or 4 days on with one individual who was in crisis. So, you know, you kind of pull one person out into something that's significant with the state police department that will decrease the availability, but we always have somebody who can talk and listen and hear people and help people who are in crisis, for sure.
Good to know.
Yeah.
I've also, I think like many other legislators, this is my first of 4 Zoom meetings this morning. And I've got to leave around 10 myself. So
Okay.
I wanted to let you know that it's not out of trying to avoid you all. It's the demand is high. And actually, my next meeting is on a police department that is also understaffed and having trouble.
Yeah.
So I think it's true throughout, but thank you for all you do. And I appreciate this meeting.
Thanks, Dick. I appreciate you taking some time to talk and the work that you're doing too. Certainly will be putting pressure on the administration. I think you're right. And I'm not sure if Seth did jump off. He said that he needed to. Okay. So thank you, Dick.
Thank you.
And Christelle, and then Dane.
Hi again. I just wanted to comment on some of what was talked, some of the things that were talked about. So with the bonuses, I will say that there has been a psychological boost, but again, it's short term. So like once those funds are gone, you know, the demands continue to increase, and then it continues to make mental health practitioners feel overwhelmed and, you know, have to make all these choices on a personal level. I know for me personally, I've helped out with crisis on the per diem side, and it's been really challenging because I'm balancing school-based and per diem crisis. And they're different realms, but at the same time, you know, sometimes I see kids from my school who are in the ED or their parents who are in the ED, and I'm screening them. And with the turnover rates too, it's just like there's the work process, there's a loss in communication. So like for me personally, I have found myself having a lot of hiccups providing per diem crisis work just because I am unfamiliar with their workflow. Or I have an idea, but I really don't know. I really don't know what it is actually to be a crisis clinician, but I have the credentials to do it. You know, and then I wanted it to say for the teachers too, we've had multiple teachers who have resigned. They resigned right around winter break because of social emotional concerns, because of the behaviors that we've seen in schools. Like right now, I have a kindergartner who is completely withdrawn from education because emotionally he is not where he's not there. Our second grade class is very difficult because they were the kindergartners who were when the pandemic started, they were just starting kindergarten. And then when the shutdown happened, they were home. So a lot of the second graders are experiencing a lot of challenges and demands put on them that they don't understand because emotionally they can't handle the academic component. And it's unfortunate to watch teachers resign who were once very passionate about their job resign because of the behavioral and emotional concerns that happen within the classroom with the expectation of getting the academics done.
Yeah.
So that's what I want to say.
Thanks, Christelle. And Dane.
Good morning, everybody. And thank you, Lorna. And just want to really just say thank you, everybody, so much for your work coming on 2 years of working through the pandemic and understanding that you've been carrying a lot of weight, and hearing that today. And just want to say thank you so much. I just wanted to make sure to put this out there while as many people were online as possible. Just as far as some of the things that have been brought up, really that I see, Lorna, you said things like predictable and scheduled rate increases, right? And I think we're kind of in this situation now where we can see like a 3% rate increase, and then we hear, no, it should be 10%. And as legislators, we're kind of working between those two numbers. And I just want to put a big plug for a piece of legislation that's out there, H 153, which was passed by the House. Now it's in the Senate Committee on Health and Welfare. And it's really trying to build in a calculation to say, what is the cost of living adjustment that is appropriate? Because I think that there's a recognition that for so many years, that's not built into the budget. These Medicaid rate increases have been level funded for many years in the past, and we have a lot of catching up to do.
Yeah.
And so, first of all, what this bill, if passed, would do is take a deep dive as how far have we fallen behind? And then looking at how do we build in, essentially, just so that we can see from an objective point of view, what is the appropriate rate increase for this year? Is it 3%? Is it 2%? Is it 10%? And yeah, I just wanted to put a plug out for that
Great.
legislation.
Great, thank you. I think that's really important. Yeah, and I think you said, it's been level funded for so long, and as Dick said, that becomes a decrease, right? So in some ways, we've been cut year after year without having any increase. And so really looking at where we are makes a lot of sense, and appreciate that work. I'm going to actually move over to Lori Vatican, who is our outpatient and substance use director, and she's going to talk about FAST. So talking about services on demand, Dick, FAST is find access to service and treatment, and it's a new process we developed to be able to respond to the increased need. So Lori Vatican, take it away.
I'm super excited to talk about FAST, but I have just two things to say. One is legislators, I am so grateful for you. I reached out to all of you around the 10% increase, and I heard from all of you. If you didn't email me or your secretaries didn't email you, you yourselves reached out, and that meant so much to me. Born and raised Vermonter, I'm so proud of you guys. I just have to say. The other thing I want to say is that within this pandemic, there has been an epidemic, which is substance abuse. And so we started an intensive outpatient program 2 years ago to meet the needs, and it is thriving. And then I had the opportunity to hire a substance abuse assistant director, and he's taking it to a different level, Alex. But let me talk a minute about FAST. Again, it's find access to services and treatment. We opened up January 3rd of this year. It was a response. This is a great innovative process, and it's designed to help people when they need it. So we began the surge literally the month after COVID hit, and the demand for clinical care was off the charts, and it's been that way consistently for the last 2 years. So we had to create something. We had to think bigger. And so a team of us came together, Amy Fella, Jason Fleming, Heidi French, Alia Reeve, Julia Puglisi, and myself. And we met consistently from October to January when we opened up FAST. So the idea of FAST is people are able to come through the doors, get their needs met immediately. They are teamed up with right here at Lead Hill Drive, this kind of west wing we turned into FAST. So the person comes in, they meet with universal access. And then they're immediately directed to a case manager and a clinician that work together. And we have decided on the clinical approach for this to be a collaborative network informed approach. Why? Because there is no judgment in this approach. It is absolutely a skill of deep listening. So we trained up the staff and we'll continue to train them. When they walk in the door, we measure the disturbance from 0 to none, all the way to 10 being the greatest disturbance. What are you experiencing now? We provide the CNA informed care. And again, we ask them at the end of session, again, from 0 to none, to 0 to no disturbance, all the way to 10, the highest disturbance are you? And I will just tell you, on Friday, a couple came in grieving. They should be grieving something, a big loss anniversary coming up for them. They came in, they both identified 9 disturbance. We were able to give them a CNA informed session. They left at a 1, feeling relieved. Now, we couldn't bring that person back. Obviously, the person had passed away, but we were able to meet them where they were, and the reduction in the symptoms of anxiety, depression, grief. And so this is really this new idea. We had the opportunity to present it on a state level, and other DAs are wanting to know more about it. We're also doing a satisfaction survey as folks are leaving. I do have a testimonial that I'd like to share from the hospital. This came to me this morning. How wonderful. So I'm gonna play it for you now.
Good morning.
Oh.
My name is Nancy Iserman, and I'm a social worker at Southwestern Vermont Medical Center. And I wanted to talk about my experience with the FAST program. When it initially came to be, I was a little hesitant that it was just a name change and wouldn't get the patients what I wanted them to have. I was delightfully surprised at how quickly the response was from UCS with a particular patient of mine.
And I also know that Alex, my assistant director, will share with you another testimonial.
Can you hear that? Can you hear that okay?
No, can hear you.
You still can't hear it?
No. So tell us what it says.
It's a testimony from a current client that has been receiving services for the last couple of years. I can send the video out.
That'd be great.
Yeah, not sure why it's not playing.
If you send it to Heidi, Heidi's going to send out various things to the legislators after. So we can add that to the packet.
I will send it right now.
Thank you.
So Lorna, in addition to these, so the response has been overwhelming and wonderful, and you can feel it as one of the clinicians. So I'm running the FAST program, but I'm also one of the clinical staff that jump in when needed. It is an absolutely amazing experience to be able to see people get their needs met in the moment that they're in distress. And the other wonderful thing about this program is that we work collaboratively so well with our community. And this was an opportunity for us to streamline people right into, whether it was Turning Point or Sunrise Family Resource Center or wherever it might be. So that's the other richness of this program. So we're sitting with them, alleviating those symptoms that they're struggling with, but we're also plugging them in. I had someone call endorsing SI, suicidal ideation. And when I met with this, it was a single mom. She was just overwhelmed with being the only one caring for her children. By the end of that session, we had her in childcare, her child in childcare, and we were able to find state funding to cover it. And all of a sudden, this mom was was so relieved and just felt connected. So oftentimes it's when people feel alone and they feel like things just feel really overwhelming. And when you just listen and provide love, compassion, care, they really do. There's a spontaneous healing that happens. And so United Counseling is provided this service, and I just can't say enough about it.
That's great. So really people who could call or literally walk in and get taken care of in the moment. They don't have to be in crisis. And sometimes we see them for a couple of times. Sometimes we might open them as a client. And sometimes we just do exactly what Lori did, is help this single mom in the moment, help alleviate some distress, and get them connected with other support systems we found that everybody was coming in and we just didn't have any place to put them. And so we created this as an opportunity to be able to give people what they need in the moment without having to go through the process of opening. Because as you can see from the numbers, we have a lot of people on the wait list. And so we're hoping to alleviate some of that pressure while at the same time providing a really innovative, high quality service. So thank you, Lori, and everybody who's jumping into that program. And Head Start. I'd like to talk a little bit about Head Start. I'm sorry that Seth had to leave because I know he's early childhood. But Head Start and Early Head Start provides high quality childcare and education. We know that access to quality care and education is essential in keeping working parents in the workforce. And we certainly know that now more than ever with the pandemic. And so Betsy Rathbun-Gunn is here to talk a little bit about that.
Yeah, thank you. Good morning, everybody. And I know that you all know how important the work is that we do around early childhood, and especially the childcare that we provide to the community. We all know that in our economic challenge that we have right now, childcare is really, really critical to get employees being able to get to work. And we have a workforce shortage too. You know, it's the same situation all the way around. But we have this beautiful new spring building that if you have not seen, I invite you to come and see it. And we have 5 classrooms in that beautiful new building, and only 4 are staffed right now. So we have an infant toddler classroom set up, ready to go, with no staff available to be able to serve those 9 kids that could be part of that program. So that's really an impact to not only our program, but to the community as a whole, because we do have a long wait list. It's not like we don't have families that need those slots. We desperately need to fill those slots with kids. But our difficulty has been the same as what you've heard before, you know, low wages, low compensation, the difficulties around COVID. 40% of my teaching staff have come down with COVID, even though they are fully vaccinated. I was very proud of UCS's stance early on to get us all vaccinated early on in November. But that doesn't mean that there haven't been breakthrough cases that have continually impacted our staffing and our teachers. So, you know, again, the bonuses are great. We also have been able to participate in bonuses through the BAA right now. There's an initiative to be able to give additional bonuses to early childhood educators. I'd like to change that one word from educators to staff. It's very difficult when I have cooks, bus drivers, family support workers not eligible for those bonuses. It really separates us out, and that isn't something that we need to have happen right now within the workforce. We need to be seen as one, and we need to be seen as all together. The other point that I just want to quickly make is around attendance versus enrollment. You know, H171 has been extremely helpful for us in trying to look at some of the professional early childhood practices. But we really want to encourage CDD and the legislature to think about having our funding for subsidy, our child financial aid program, to be paid based on enrollment. It's been very difficult to go through this based on attendance because, as you can imagine, families are working, they're not working, they have COVID, they don't have COVID, they, you know, their attendance has been back and forth. And we still have to hold those slots, right? It's like having a restaurant say, you have to hold that table even though you can't seat anybody at it. We would never ask that of other businesses. So it's really important for us to be looked at as, you know, being fairly compensated so that we can fairly compensate our staff based on enrollment, those families that we enroll, not their ability to always attend due to their own hardships at time. And the other piece I just want to let you know about is that we continually serve families that have children with special needs. We have a mandate with Head Start to serve 10% of our families. We are up to 40% of our families are either having children on IEPs or on IFSPs. So the needs of our children have increased substantially, and that means that our teachers have to be better trained. So I really appreciate the thought around the student student loan piece. And I know Rebecca had her hand up earlier to speak about that because she's on one of the committees. So Rebecca, do you quickly want to talk about that?
I can. I'm Rebecca Bishop. I'm Assistant Director working with Betsy in our Early Childhood Services Division. I like to say I'm a Shasberry resident now, and I'm also a board member of the Vermont AEYC. So one of the projects that we've been working on there is the loan repayment for teaching staff, which is due to come out in the coming months with Vermont AEYC. I see this as a benefit because when staff have graduated and they've received their degrees, including a bachelor's degree, which is what we're really looking at for a higher quality, well-prepared staff member, they're eligible to apply to the program and get some tax credits and some repayment toward their student loans. I feel like this is a system that could be duplicated to other industries, as we've been talking about with our mental health staff. We have a model a little bit set up now, and we could look at that for how it could be replicated in other industries. Thinking again about education, we have the TEACH program with the associate's degree, and newly including the bachelor's degree program. And that is what we need more of, is the higher degree, the bachelor's degree, the master's degree. And again, how does this translate to our mental health system staff as well?
Great, thanks, Rebecca.
Thanks, Rebecca. And I just want to end with a little paragraph that I had reached out to a parent to write about how significant it is to have childcare. So she said, when I enrolled my daughter in childcare at Bennington County Head Start, Early Head Start, my primary goal was for her to have high quality setting to learn and grow while I focus on my career. When she was home with me, my options were very limited to the type of work that I could do, and I wasn't making enough money to help support the family. Once she was attending full-time, the job market opened up to me, and I was able to focus on my resume and interviewing, landing an amazing job that furthers my career and contributes to my family's financial health. Every day I go to work, I am confident that I can continue to work as a dedicated employee, knowing that my daughter is thriving in care. I know I'm speaking to many people on the screen that get it, but really, the time has come that we need to provide comprehensive childcare so that we can get as many people back into our workforce as possible. So, thanks.
Thank you, Betsy. That's great. And I wanted to finish up with hearing about what it means to be a certified community behavioral health center, or CCBHC. We are actively preparing to apply for a SAMHSA grant, and I'll turn it over to Amy Fella, Operations Director, and Alex Figueroa, Assistant Director of Substance Use, and they're the leads on the project. So they're going to talk about CCBHC and why it's important.
Morning. As Lorna noted, UCS is ready to apply for an expansion grant for CCBHC, or Certified Community Behavioral Health Clinic. Receiving the funds from this grant will give us an opportunity to expand the scope of services, the array of services, and will broaden the reach of those that we are able to serve. The definition and criteria was set at a federal level through the Excellence in Mental Health and Addiction Act. Through CCBHC, you're required to provide 9 different types of services, and those are provided either directly by our agency staff or partnering in contract with community partners. The care is emphasized on 24-hour crisis care, evidence-based practices, care coordination with local primary care and hospital partners, and a greater focus on integration with physical health care. Services are including 24/7, 365 mobile crisis team services. And as you heard from Rachel and others on the screen today, staffing is a big concern of our current program. CCBHC funds would give us an opportunity to leverage some of the salary inequities that we have by being able to increase those salaries. Being able to provide immediate screening and risk assessment for mental health addictions and basic primary needs. Easy access to care, something that UCS focuses on a daily basis, but there is certain criteria and definition that goes with CCBHC certification. And with that access to care, the one really different piece is that we would provide services beyond our current catchment area of Bennington County. And through CCBHC, we would be required to provide services for underinsured, uninsured, and those that are not able to pay. CCBHC also has some tailored care for active duty military and veterans. And we would expand care coordination with local primary cares and hospitals and social services. There is an emphasis on commitment to peers and family, recognizing that the involvement is essential for recovery. And regardless, again, of people's ability to pay, we will be able to provide the broad scope of services that align with CCBHC. Alex?
Yep. Thank you, Amy. And so just to kind of piggyback what off Amy's saying, so one of the components that the CCBHC will address, obviously, is financial barriers, which insufficient funding poses barriers to access and behavioral healthcare, which I think we talked a little bit about that today. So through a CCBHC model, through a prospective payment system. And so following this meeting, Heidi will send out some documents really breaking down what that means, because it really talks about two different models. There's a PPS1, which kind of focuses on like a daily rate, and then a PPS2, which focuses on more of like a monthly rate. So through this prospective payment system, it addresses this area by paying clinics a Medicaid rate that includes anticipated costs of expanding services and also services to new clients. So this model generally will support, expanding access to care through enhanced workforce, a stronger response to either crisis or not just mental health, but also addiction as well, enhancing patient outreach, education, and engagement. The one thing I think it's important to highlight, if some of you may know this, but we have one already CCBHC in the state of Vermont, and that's the Claire Martin Center. I think they're on year 2 of the demonstration grant, which is very exciting. And some of the benefits, that we've seen is increasing access to mental health and substance use, largely due to the availability of same-day appointments, obviously reduction in emergency department hospital visits as well. And it just helped kind of mitigate some of the effects of mental health and substance use service workforce shortages. And so it really helps with kind of the hiring and retaining staff.
You talk about I'm not sure who's got this, but the funding and then how it's important to the state, because I think it's going to be bumped to the legislature at some point.
So the funding for the expansion grants, it's $2 million a year for 2 years. And the one really great point of that funding too is that we're actually paid for what it costs us to provide a service. So right now we're paid per member for their month to make sure that they receive a service, but we're paid for the actual cost of the service delivery. With, as Lorna noted, going to the state, Department of Mental Health has partnered into a contract with the National Council for Wellbeing to start talking through what are the benefits of aligning this model at the state level. We're also going to send you an impact report from the National Council, but some of the highlights the demonstration states have in those reports is that there is an increase in access to mental health and substance abuse care. And that's largely due to increased availability of same-day appointments, expanded hours of operation that is facilitated by increasing hiring and concentrated efforts to conduct outreach to underserved groups. There's a report in reduction in ED and hospital visits, which we know we're always focusing on that reduction of utilization in our EDs. And that too leads to cost offsets. It helps states mitigate the effect of mental health and substance use service workforce shortages by enabling clinics to hire and retain that vital staffing. Part of the work that we do in the background is making sure that we have a good staffing plan, as well as looking at competitive salaries. Improve rates of initiation, engagement, and follow-up for mental health and substance use care. That engagement is really crucial to make sure that folks get to the point in their journey, aligning with their treatment plans. Increased access to comprehensive evidence-based services to curb the opioid crisis, including MAT. And again, in the background, Dr. Reed and Lori Vadigan are starting those conversations about how we can partner in our community to bring that forward at UCS. And also results in improved integration of physical with mental health and substance use care, including offering on-site primary care services. So when somebody comes in for their mental health appointment or group, they'll also have an opportunity to have their weight and height and BMI and blood sugars and things checked to make sure we're providing that whole health care.
Great. Any questions on that? It's a big undertaking. Like Amy said, it's $2 million a year for 2 years with the possibility of an extension grant beyond that. The hope is that perhaps the state of Vermont will bring this in as a payment mechanism to be able to enhance Medicaid dollars and be able to look at it, being able to embrace this kind of payment model, which would be helpful. David, go ahead.
Who have you been talking with, Lorna, at the state to try and make that happen?
So Emily Hawes, the Commissioner of Mental Health, has gotten a small group together to look at CCPHC, and also is either working on or has already engaged the National Council in a contract to be able to work with the state of Vermont to see how it would fit and what the state of Vermont would need to do in order to bring in the model.
And the state would be willing to work with UCS, even if it's only UCS, or are they thinking it needs to involve other agencies?
We have not engaged them specifically around UCS. We will, regardless of whether or not the entire state embraces the model. Probably the majority of designated agencies are going to apply for this grant. We don't suspect everybody will get it because there's only, I think, 136 or 126 grants available, but we do expect that a few will, because Vermont was the last state to jump on board the CCPHC, and Claire Martin in Randolph was the only one that applied for this last one and received it. So there's definitely work to be done around how this is beneficial to the state and whether or not they would be interested. And even if we did a pilot project, the state did a pilot project with, say, us if we got it, or the other the other mental health centers if they receive it, to even start out with a couple and see how it works for them.
Yeah, great. It sounds like a great opportunity.
It is, and it's very similar. It's kind of similar to the FQHC, so the Federally Qualified Health Center, where they get a higher level of pay. Yep. Yeah, it's a different kind of payment model. So we're excited about that. Any other questions? Go ahead.
Yeah, I was going to say, let us know if we
Sure.
can, if there's anything we can do.
Absolutely. Thank you. So thank you, everybody. Is there anybody that didn't get an opportunity to comment? Unfortunately, Tim just jumped off. Who would like to share anything or ask questions?
This is Mary Morrissey on the phone, and I would just like to take the opportunity to thank all of you for the amazing work you've done through very challenging times. And, my committee deals with more of the bricks and mortar, which is, can affect your programs and the job you do here in the community. But we've got, just to give you quick updates, our Justice Reinvestment initiatives include community transitional housing, domestic abuse programming, and addiction recovery programs, which, we're saving money in some areas of corrections, and we're trying to transition those who have been incarcerated back into the communities in an appropriate way. But in listening, this morning, to all the challenges that you all have been facing for some time, I am wondering if, first of all, you good folks would have a challenge in being part of those programs, or if you were reached out to further run some of the expansions we're looking at. Because I always look at the brick and mortar as we can build something, but if we can't fill the positions that are needed to run these, these support systems for folks, then what are we kind of creating? So could you possibly respond? I know it's probably not likely at this given moment that you would necessarily be able to jump on, even though I know you've done amazing things to support different initiatives and that, but what would be your take on this at this moment?
As far as being able to join in with supporting?
Well, join in and be supportive. I know you always haven't from, as much as you can, but again, some of these initiatives are important, obviously important to have folks transition into, back into the community, so that you're not going to have to deal with possibly more intense challenges with some individuals if they're not getting the chance to have the programming that they need.
Right.
So
yeah, we are great collaborators with and have great partners within our community, and we would absolutely be partnering in any of these initiatives, certainly in the community, to be able to support folks staying here and being successful. Reaching out. I know Turning Point is looking at recovery housing. We've already been having some conversations with them about how we can support the recovery housing, because Turning Point is recovery, not treatment. So being able to help with the treatment side of the house, we absolutely are right there with our community partners.
right, and I should have said that my committee is institutions and corrections, and like I said, more of the bricks and mortar, but we have been dealing with other such issues. We actually had a presentation on the funding that comes, that they work with the housing authorities here in the state, and we've talked about the programming with Pathways in regards to the addiction recovery housing in Bennington. And I think the one on deck to be looked at is, first of all, is the women and child housing initiatives that they're looking at. There is also going to obviously be the men's recovery housing up on Gage Street, but we have not heard for that in that. Just to give you an update on a couple of other quick things we've got, which is a little challenging, the Woodside facility that was supposed to be in the town of Newberry. The facility was going to be built, and that the project has stopped at this point because of the town having some concerns with it being located in their area. So we're looking at some possible temporary or long-term site. Might be the state-owned property of the old Windsor prison. And not that we're saying we want it to look like a prison. There are opportunities on that property that could possibly turn it into a kind of a treatment center, and it's a beautiful property that you could have other things on it, that I think would be beneficial for our younger population that has challenges. We're also in the process, and it should go to construction in 2023, is the replacement of the Middlesex facility. And that's for the secure residential recovery facility. Let me see. And then we've been obviously talking a great deal about homeless housing, and I think that is probably as much right now that would deal kind of with different initiatives that you all work with. But I'm hoping that as our transitional from the correctional systems work is that we'll be able to get you folks in a little better place, finance, so that you can have the staff that could help with these programs further. I know you always stretch yourselves to do what you need to do in the community, but we've got to step up to the plate too to make sure that happens. So again, thank you for all the incredible work that you do. I know it has been it's always difficult, but it's been especially difficult the last 2.5 years.
Thank you, Mary. And Dane, you have to run, sorry.
Yeah, thanks, Lorna. I'll just say really quickly, probably everybody's on the chat, but just thanks again for all of your work. And I wanted everybody to know Human Services Committee and our budget recommendations is looking at a proposed $8 million increase in ADAP, specifically for substance use programs. And the focuses are employment support, housing, recovery housing, for example, and prevention. And would really love to hear any of your feedback on that. If any of you want to talk further about that, please feel free to reach out to me. I included my email and cell in the chat there. And also just wanted to let you know that crossover date for policy is approaching, but Human Services Committee has expressed interest in policies to support substance use treatment, prevention, recovery. And if you have any feedback, I can talk about some of the things that we have on the table, but I'm personally am especially interested in any ways that state policy could remove potential barriers to treatment for families. So yeah,
Thanks,
anyway,
Dane.
I do need to hop off. Thank you
And
all
I
so
really
much.
appreciate your work because I know you guys are working really, really hard. So thank you so much.
Thank you all. Take care.
Hey, Lorna, Mary, it's Alex. Nice to hear from you. I just wanted to comment, just to let you know, UCS, we are at the seat of the table as relates to, recovery residents, specifically not from just recovery housing component, but also, with pathways. So UCS has engaged already with conversations with statewide leadership on what that partnership could look like. I just mentioned it because I just want to let you know that is happening behind the scenes. I know next week, Lori and myself are meeting with leadership from Pathways just to kind of discuss, updates and both from their side and our side and what that could look like. I know Pathways has the grant that I know they support folks coming out of corrections, and so which I believe that one of the I think that's 15. I think that 15 folks that are coming out of DCO, so they're able to house. So we, just my point, we are part of those conversations, and I'll definitely keep you updated on the work that we're doing.
Right, and Alex, I'm very well aware that you folks are in that arena, both arenas, that you're involved in it, and it was some of the other programming that I wasn't sure if, because again, we can only stretch people's and agencies so thin. That, but no, I'm very well aware that you're very involved in it. We've been at meetings before in regards to it, but I was definitely aware. So thank you again for the good work. And yes, if you would keep me updated, that would be great.
Thank you all very much for this, for being here this morning and for hanging in there. And I appreciate all the work that you do. And it was a great discussion. Be well. We'll talk soon, I hope.
Thank you.